Hello, good afternoon. Thank you very much for the organizers of the panel for having me and for SAGES as well. Again, my name is Michael Awad. I'm at Washington University in St. Louis, where I serve as director of the Robotic Surgery Program for our healthcare system, which is known as BJC Healthcare, also a Director Simulation Center there. I do have a number of educational grants with industry, the most relevant of which is with Intuitive Surgical. I also serve as a consultant for Intuitive. In addition to disclosures, I have a couple of disclaimers. One, and what I'm going to talk about today is not a one-size-fits-all approach. So what works for us may not necessarily work for your institution. And also to say that we haven't figured it all out. We are still learning and growing as we're learning from each other in these. And towards that end, we were certainly not first out of the gate with robotics by any stretch of the imagination. In fact, we got our first robot 7 years after it was FDA approved. There were several other institutions that had robotics well before us. And for the better part of that first decade of when we had the robot, we were pretty flat with our volumes. You can see, it's reasonable volumes here, predominantly driven by traditional service lines, urology and GYN. I was the first general surgeon to do robotics starting in 2009. I'm that little blue blip at the bottom. And at around 2017, at the end of that graph, we had been doing about 600 cases a year, not gangbusters, but reasonable. However, our utilization was poor. We had 3 robots, 2 SIs and an XI with utilization in the 20 to 30%. And we had a system at St. Louis Children's Hospital where it was 6% utilization. But yet, we had surgeons doing robotic cases, but we did not have a robotic surgery program. We had surgeons saying, we need more robots. And the hospital administration saying, no, we don't need more robots. What we need is more effectively to use the robots that we have. We had industry saying, hey, do you want to buy a robot? And our administration saying, no, we don't want you selling us robots. We need solutions. We need partnerships, not just transactional relationships. So what did we do? Well, we first took a deep look inside ourselves and said, what were the issues? Like I said, we did not have a true program. We had no structure around scheduling. We had no oversight, coordination, engagement, or accountability. So right around 2017 is when we started making some changes, and this is our volumes since then. And part of what I'm talking to you about today is part of that story. You can see, by the way, the COVID impact in Q2 of 2020. So we had a kind of a mini strategic planning retreat, and this is what our focuses were on: creating alignment and shared goals, leveraging existing robotic resources, and I want to emphasize that. At that inflection point, we did not buy a single additional robotic system. We did not add any additional robotic block time. We just made better use of what we had. And then creating the right culture of safety and quality. We created an aligned vision for our patients, for our clinicians, and for the enterprise, and this is our vision, which is simply to provide the optimal surgical approach for each patient at all times. And I'm going to kind of, piggyback or echo on Dr. Samreen's presentation about kind of the 24/7 access. And if that system is the right approach for that patient at that time, then that's what should be supported. And we had some, discussions within ourselves. Who was in charge? What are we trying to accomplish? Do we have metrics? What are our outcomes and quality going to be? What is best in class, and what does that look like? And how do we measure our outcomes? How do we measure success? So now we're actually closer to 1,800 cases a year at Barnes-Jewish Hospital. And how did we get there? And that's really by creating structure and accountability. All the parameters you see on the left side there, each of them can be a talk in itself. We won't have the opportunity to go through each of those in detail, but I just want to highlight some of those aspects in our talk today. And we started with getting organized. We started with program administration, developing a governance committee. We have 14 hospitals within BJC Healthcare. Not all of them have robotics, but of the ones that do, we formed an alliance amongst those, and we meet every other month. We talk about how we can work together, how we can face common challenges, how do we monitor our volumes and compliance. Within Barnes-Jewish Hospital, which is kind of the flagship of the system, we then also got organized internally. My role was created as Director of Robotic Surgery for BJC Healthcare. We have what's called an operations committee, and this is the group that kind of is boots on the ground, that handles kind of day-to-day, week-to-week considerations. Are things flowing smoothly? Are cases well prepared for? You can see the team members that we have there on the org chart: coordinators, resource nurses, RNFAs, and finance folks, and so forth. We also have a robot steering committee, which meets every month like clockwork, bright and early at 6:15. This is, every service line is represented, from ENT to HVB to GYN to urology and so forth, with clinicians. We have our program administration. We also have our intuitive partners at the steering committee, which was novel for us. Before, we kind of kept them at arm's length, but we actually found it was more helpful than not to have them at those meetings so that they could be present to address issues and questions real time. The robotic surgery nurse coordinator was a new role that was created 4 years ago. The job descriptions are listed here, which was very kind of spelled out and clarified and publicized. Who's the point person? Who do I go to when I need help? And by the way, happy to share any of these materials with anybody if of interest. We focus on staff training, again, towards Dr. Semreen's excellent presentation. We wanted everybody, day or night, weekday or weekend, to be familiar and comfortable with it. Not only did we develop training programs for new hires, but also for those who had been trained on robot, but kind of a maintenance of training. An annual training occurs every year with kind of a rubric and checklist. Again, these documents we're always happy to share. We developed dedicated bedside assistants. In our platform, it is a nurse first assist, although some places use PAs, some places use scrub techs. And what we found was these individuals provided not just better efficiency, but also standardization. It didn't depend on who your bedside assistant was from day to day. You knew you were going to have the same quality of care regardless. And also for training, once they themselves got out of the learning curve, we found that the RNFAs themselves were teachers. They could help our new trainees when they were at the bedside with docking. Even some of the new faculty, they could help and kind of streamline the docking and different port site considerations. And they're probably the ones in the room who have some of the best knowledge with our robotic systems. We got our scheduling acting together. And one of the main things that we did early on was to say that only robot cases can be done in robot rooms. And I'll have to say, I was one of the naysayers of this originally. As a surgeon, I liked flexibility. I like to be able to put my open cases, lap cases, robot in my block time. However, I've since come to be a firm believer in this, and this is what optimized our utilization. And I still have, time to do my other, flex endo cases and so forth in other blocks. We do have kind of a release schedule shown here to allow non-robot cases to still be done. We developed clear credentialing pathways for 3 different tracks. Those that were coming in with experiential training that is brand new to robotics, those who had been trained in residency or fellowship but are new to their practice, and those who are experienced robotic surgeons who are transferring from another institution. Our credentialing, though, goes just beyond kind of checking the boxes of numbers of proctored cases. We developed kind of a pathway here that involves what we call kind of provisional credentialing, where we see kind of a gateway towards getting on board. Do we have support from your division or section chief? Do we have case volumes to support that? Preceptorship, we make a distinction from proctorship. A preceptor is one who's really there to coach you on the procedure, tips and tricks, and so forth. The proctor is really meant to check you off on the proper use of the technology. And then it doesn't end once you get your initial credentials, what we call continuous development or maintenance of the credentialing as well. And then data. We're very fortunate to have a very strong data analytics team that looks at operational KPIs. These are our volumes that we track on a monthly basis by service line. This is the service line block utilization by surgeon, and this is showing your block time utilization with a heat map, so to speak, where we can kind of look and see, utilization's getting low, we have a discussion, there's kind of, flexibility in this, but that's the kind of data that helps drive our decisions. Block management. is relayed there. We also look at case scheduling accuracy, people who are overbooking or underbooking their times. Turnaround times are tracked very closely. We used to have terrible turnover times of 45 minutes between robot cases. Now we're down to 29 minutes on average. Financial KPIs, we have, the data is unblinded. So every surgeon can see how much their cases cost compared to their peers. And so this is kind of the transparency that, again, can be a little bit uncomfortable at first, but we found is very, very critical. This is actually driven from Epic. We also have a receipt, so to speak, where you can at the end, as soon as the case closes in your Epic inbox, you get a list of how much your case costs down to every instrument, robotic and not. I used to look at every single one of those lines. Now I know to the dollar how much my case costs, and if it's off by a little bit, then I'll look and see, oh, was there an error, was there an issue? We've actually been able to drive down our costs by 27% with some of these programs. And finally, the clinical KPIs. We're able to look at key things that affect our patients, readmission rates, infection rates, transfusions, and so forth. And I know we're short in time, but if you're to remember nothing but this slide, this is the one I want you to focus on. This is what it's really all about and for our patients. You know, people will say, well, are you doing robotics at, you know, and how is it better from lap? But over a 3-year period, if you focus on the black line, the solid black top line, that's our open case volume, which went down 7%. And not because it was we converted from lap, it was because we converted from open. And so we had a concomitant rise in 7% in robotic surgery, drawing down our open. And again, there's no argument that open, minimally invasive surgery is better than open. So we won't be able to talk about curriculum today, but this is obviously a key part of safe practice and training. And just to close again with a couple principles, this is not a one-size-fits-all. Basic principles apply. Find the model that best suits your staff, program, and institution. Thank you again for the opportunity to speak today.